Welcome to the 54th InterScience Conference on Antimicrobial Agents and Chemotherapy. I'm Michael Schmidt, and this is ASM Live. I'd like to thank you all for joining us here this afternoon as we discuss some of the science that's going on here at ICAAC. This week, along with the program committee, we've selected some of the talks and asked some of the presenters to be with us to discuss their exciting science. I encourage any of you out there on the Twitterverse or on our chat room, should you have questions, please post them and we'll get to them. And similarly to the members of the audience, I encourage your questions as well. Today, I'm joined by John Bosso from the Medical University of South Carolina and Tonya Smith from the University of Utah. Together, these two investigators asked a question that every hospital on the planet is currently asking, wondering whether each day in the hospital increases the resistance risk associated with the infections that our patients are getting. For patients who acquire infections while in the hospital, each day of hospitalization increases that risk, that the infection will be caused by a drug-resistant bacterium. You only have to pick up your morning newspaper to know that drug resistance amongst the microbes is increasing with each passing day. The researchers here are going to share with us the exciting results that they presented here this morning at ICAAC. So welcome, Tonya, and welcome, John. You're my colleagues at the Medical University of South Carolina, and full disclosure, I had nothing to do with putting these poor souls on the couch. That was the program committee, and so they're here, and they're going to share with us what they've learned. So, Tonya, we're going to start with you. Okay. Since you were the presenter this morning, what was the question your study asked, and what did you learn?
So our ultimate question was, kind of as you were saying a minute ago, to determine if there is any relationship between how long patients are in the hospital and the likelihood of them becoming infected with a multi-drug resistant gram-negative organism.
So this is this mysterious term that many of us hear out there called length of stay, yes, or LOS.
Yeah, so we wanted to see if there was any correlation between how long patients have been in the hospital and likelihood of getting one of those organisms. You know, we often treat our patients in hospitals based on the assumption that the longer you are in the hospital, the more likely you are to acquire one of these hard to treat bugs or microorganisms. And so we just wanted to see if there were particular factors that influence that. If the type of infection a patient had any impact on the likelihood of drug resistance and that type of organism.
So were these hospital-associated infections or infections that the patient came in with?
So it was both. It was hospital-associated infections, but we also have patients that were included that did have some baseline infection.
So they came in with the microbe already on board?
Some of them did, yes.
So let me ask the next question. Why did you study this? Was this a funded industry trial, or was this simply so that you could provide better care to your patients?
I think very simply it was just so that we can provide that better care for our patients. And as you've mentioned, resistance to antibiotics is a major problem that we're facing right now. And I think that we just wanted to see if we could quantify duration of, or length of stay, as you said, if we could quantify some of these different things that would help us understand the risk factors, maybe that we could help patients avoid having to get into the hospital, avoid being at risk for infection. If we could figure out what some of those are and maybe figure out how to avoid them, then maybe we could prevent them from getting in the hospital to begin with and from getting these hard to treat organisms.
Now, both of you are hospital pharmacists, and to the general audience out there, they may not know that pharmacists have a very active role in hospitals, especially in helping physicians understand the issues associated with infections, what drugs are appropriate, and they're really part of the integrated healthcare team, whereas most folks just think pharmacists dispense pills. So John, you want to comment a little bit about the importance of the pharmacist? And I know they're a major attendee here at ICAAC, hence the term inter-science because we're bringing in medicine, microbiology, and the whole broad spectrum of what pharmacy entails.
Well, certainly there's been an evolution in pharmacy, and the nature has changed. While pharmacists generally are still the caretakers of the drug supply and getting the drug to the patient, usually reacting to a prescription, there's a lot of pharmacists that are involved in integrated health systems, such as the one we have at the Medical University, where the pharmacists aren't really involved in filling orders and these kind of things. And as you said, they're more involved with helping physicians select appropriate drug therapy and then monitoring to make sure that that therapy is working, not causing side effects and so on. And some people have actually specialized in the world of infectious diseases, and those are the kind of pharmacists who are here at this meeting presenting work like this, often specific to a particular drug, but you see more and more at this meeting with antimicrobial stewardship, which is a program that tries to optimize use of anti-infectives, as you know, and pharmacists generally are an integral member of that team.
Yeah, that's what really excited me, that we were going to get an opportunity to talk about your work, because yesterday we had a great discussion on the value that antibiotic stewardship programs offer healthcare. And with your work, you actually have some solid data showing how that can happen. So would one of you like to comment on the real data associated with your trial? We sort of just scratched the surface. Tonya, maybe you take that?
Sure. So we basically looked at the percentage of organisms isolated from patients with infections, basically from the day of admission until discharge, essentially, to see what day of hospitalization they had a positive blood culture, urinary culture, whatever culture it was, just to see when they had that first real day of infection. And we found that, as kind of consistent with what's been published in the literature already, that the longer you are in the hospital, that risk does increase, but we actually were able to quantify that and say that the risk increases by 1% each day that you are in the hospital.
Mm-hmm. So that's another very important reason to get out of the hospital as quickly as possible.
Exactly, and I think that our data proved that you know, I think we try to get patients out of the hospital as quickly as we can for a number of different reasons, but I think this definitely proves the importance of trying to get patients out before they are exposed to one of these hard-to-treat organisms.
Could you comment on whether or not I know the agents, you figured out they were infected, but what about this whole panoply of multi-drug resistance that we keep hearing about? Did your data reveal whether as time went on, you saw more multi-drug resistant microbes? Either one of you can take that one.
Yes, and that actually was part of the basis for the research question or hypothesis. It was interesting that you asked Tonya before, why did you do this study? And one of the reasons was we had done a study and published our results on a previous iteration of the database, and we were really looking at attributable costs of these gram-negative hospital-associated infections. And we published the paper, and we received a very interesting letter to the editor that said, well, we think your study is a little bit biased because everybody knows the longer you're in the hospital, the more likely you are to get a resistant organism, infection with a resistant organism.
Is that real knowledge or
well, there are papers, and it's certainly the conventional wisdom. But before we responded to that letter to the editor, we picked one of the gram-negative bacteria that we had studied and did exactly that analysis, but found just the opposite was true. And so since that time, we have been wanting, the group we've worked with has been wanting to go back to that question, but ask it across the database in all the organisms. And while we found that in general, the conventional wisdom is true, that the odds that it's multiply drug resistant varies from one of these types of bacteria to the next. So that was new information in the field.
Well, I guess conventional wisdom would almost encourage that conclusion as well, because how these multi-drug resistant elements move depends on conjugation, transformation, transposons, pathogenicity islands. The list is long and distinguished, and so consequently it confuses the hypothetically driven question when you're asking it globally. You almost have to drill down, and then it's a nightmare to try to get the cohort to figure that out.
Sure.
Any other exciting things you want to tell us about that? I know there was 15 minutes of your talk, so it was chock-a-block full of data. So what other interesting elements did you discover?
So some other interesting findings were, we found that Enterobacter species specifically were about 5.6 times more likely to be multi-drug resistant.
5.6 times.
That's right.
Not percent, but fold.
Right. So about 56% of the isolates in our study that were Enterobacter species were multi-drug resistant, compared with about 20% with the other organisms that we looked at. So it was a pretty significant finding, I think. And something else that we found was that our Pseudomonas isolates were 44% less likely to be multi-drug resistant.
That's good news.
Which I agree. I think it's great news, and I thought it was really interesting because I think, especially recently out of pharmacy school, I am afraid of Pseudomonas, and we hear all these different things about combination therapy and different ways that we try to treat this really scary bug, and so I had expected that one maybe to be a little bit different than what we found, but we did find that our Pseudomonas isolates were less likely to be multi-drug resistant.
Well, that's rather good news for the poor soul in the bed.
Right. I think so too.
So where to next with this problem? Do you think as you write this up, you're going to get another letter to the editor?
Yes, at least one.
At least one.
Because with these kind of trials, it is not unexpected. In fact, is expected that often these trials raise more questions than they answer. And our study definitely had limitations, because people often would ask, so if you're not at the Medical University of South Carolina, you're at, say, another hospital in Charleston, South Carolina, is what we found apply to your hospital? And should you take it to heart and change your procedures or whatever you might do? And there's no way of knowing that. And that's really a limitation of a single center study, as you know, is you don't know if it applies to anybody else. Now, we think in general, these are truths that we found, and they're probably, in a very generic sense, true elsewhere. But is Enterobacter the worst bug across the hospital across the street? Is Pseudomonas less likely? Is the risk per day 1% at all
at
hospitals?
Hospital X and Y.
And so all of that, I think, needs to be explored at each hospital if they have the facility to do that.
So I guess the next question that comes to my curious mind is, where are these resistance determinants coming from? Are the patients bringing them to the Medical University hospital system, or are they inherent to the hospital system? That gets to the general applicability of, is it the same at the hospital across the street as it is in your hospital? This is the new emerging field of the resistome.
I think that's a great question, and unfortunately, I don't know any specific numbers really for what that is at our hospital, but I think it's a combination of both. I think it's people bringing things in from the community. I was just having a conversation with someone earlier about, things like wearing a necktie or a coat or something like that to work. You think about these very insignificant things and you never know what is there. So I think we could be bringing some of it in, but I think it also could be due to the flora of the hospital. I think it's a combination of both.
So I think the answer to your two questions, the answers are yes and yes. That more and more
another study.
More and more patients do show up already colonized or infected, and these days it can be with a multi-drug resistant organism. And the typical patient would come out of a long-term care facility. They may be transferred to an academic medical center like ours from a community hospital.
Because of the complexity of care
Right,
issues.
and then the second part of your question is it something we're doing in our hospital? The answer is yes. We grow our own resistant organisms, as you know, and that's a function of hospitals are a very antibiotic intensive place, and so we breed resistance, not on purpose, but that's the way nature works. So it's a combination of those two, and I think, you know, the 1% risk per day perhaps doesn't sound like a very big number, and it wouldn't be if on day 0 the rate of multi-drug resistance was 0.
But it's not.
It's much higher than that, and so you're adding to what's already a significant number with another 1% each day.
You're listening to ASM Live at ICAAC, and we have a question from the audience. Please.
Yeah, good morning. It's Michael Smith from MedPage today. I'm trying to get a handle. I think I hear you say that for each day a patient is in hospital, the risk of developing an infection with a resistant organism is 1% greater. Is that right?
Yes, but we only looked at one kind of bacteria, one class, big class of bacteria called the gram-negative bacteria, which are certainly not representative of the universe of all bacteria that infect humans.
Okay, so the obvious question is, why didn't you look at the gram-positives as well? And then I actually have a follow-up to that if I can. I don't know why you're restricted to gram-negatives.
Well, that was, it came out of some previous research in a database we had begun assembling some years ago. The hospital epidemiologist who worked with us, or is working with us, that's a particular interest of hers, is that kind of organism and that kind of patient. And that's what really drove that. So it wasn't that we consciously said we're not going to look at the gram-positives, but truth be told, most of these kind of infections are caused by gram-negative bacteria. There's one kind of probably heard that acronym, and so that's kind of the elephant in the room that we did not look at, but that's really the story behind why we focused on gram-negatives.
Okay. The follow-up question is then, I'm trying to get a handle on what's the risk of being in hospital and developing an infection of any sort, whether it's resistant or not? And does that increase day by day, or is it just the resistant organisms that are causing this change? I'm trying to get a picture of the universe. I'm restricted to the gram-negatives, of course.
Well, the CDC just published that's my particular area of interest. I study hospital-associated infections, and the CDC just published this past March for the U.S. data that the rate has dropped from approximately 1 in 20, the risk of acquiring an infection while hospitalized, to approximately 1 in 25. And the only limitation associated with that CDC trial was it was a smaller number of hospitals that they looked at than they had previously looked at. So generally, most people in the HAI world consider your risk of acquiring an infection while hospitalized about 1 in 20. And of those 1 in 20 who get hospitalized, your risk of death from that hospitalization typically is another 1 in 20 risk, or your overall risk of death from the acquisition of infection while being hospitalized is approximately 1 in 400. So looking at their data here with this 1% increase per day, and the average length of stay in a U.S. hospital is approximately 4 days, you can begin to see as your length of stay increases, the logistic regression associated with that risk characteristic. I can't do that kind of math in my head anymore. So it's your question is really important in evaluating their data.
I'm just trying to tease out the universe that we're looking at here. If I go to a hospital and I'm there for 10 days, it's certainly possible that I won't get any infection whatsoever. I think that's what you're saying.
Yes.
But if I do get an infection, is it more or less likely to be resistant, or?
Well, that's the recent data that Tonya revealed this morning. You were saying that, at least if I'm remembering your talk from this morning, you said that you were looking for multi-drug resistant determinants, 1 antibiotic, 2 antibiotics, 3 antibiotics, and share with us what you reported this morning.
So we looked specifically at organisms that were resistant to at least 1 antibiotic within 3 or more antibiotic classes. And there are several different classes of antibiotics, and their susceptibilities of organisms to those antibiotics varies by the organism. But that's essentially what we looked at, was just to see if that had any impact as well. I don't know if you have anything you would want to add to that.
Well, I think a couple important points. One is that certainly not everybody who's admitted to a hospital gets an infection. In fact, that's the exception rather than the rule. So that's an important thing to know, for the public to know, and for potential hospital patients to know. But certainly a critical number of patients do acquire infections in the hospital. And what our findings show is that the likelihood that if you get a hospital infection is resistant, what we're calling multi-drug resistant, based on an accepted definition of that term, the odds of that goes up with each day you're in the hospital. But nobody should construe this to mean that everybody comes in the hospital and gets infected, let alone with one of these organisms. There are messages there both for healthcare providers and for patients.
Another question from the audience. Thank you.
Yes, Dr. Thompson Tuba. I am reporting for Cameron Concord in Germany and for Swella USA Magazine. I happen to be a physician, and I've also worked in issues related to nosocomial infections or hospital-based. My question is to the presenters, and it has to do with whether you did some comparative studies, because a good example in Africa, where we have a lot of infectious disease conditions, the samples that you get, will always be very big. I wonder whether in a very advanced country like America, where basically healthcare is formatted in a way that you really don't have much room for many differentials before you make a diagnosis and you treat, and in that case you are actually treating the cause, unlike where most of the facilities are not available and people are doing polypharmacy. What would these issues that I have raised have contributed in making your paper different?
You're asking a really challenging question. There's many questions within it. First, the value of the laboratory, the quality of the specimen, and I can just sing the praises of our hospital lab, directed by Rick Nolte and Lisa Steed. They're wonders, and we get really great data from the laboratory in terms of drug resistance and things along those lines in a very timely manner. You folks want to comment on this gentleman's question?
Well, it's an interesting one and an important one, and certainly could cause results of a study like ours to be different in different healthcare environments, simply because part of what you're asking is, there's one implication if you know what the causative organism is and you know what antibiotic will treat that organism, versus we think it's infection, we think it might be this organism or these other three, and we're going to give antibiotics that would be effective against that array. And that's a much different environment, but it's not something we don't deal with in the United States. And certainly rapid diagnostic techniques are shortening the length of time between when the patient comes in and when we know the answer to those questions. But it's often still 2, 3, 4 days before we know that we're giving the right antibiotic. And it's that kind of treatment approach that you described, where you give polypharmacy, broad spectrum coverage, whatever, that we know can, if it gets out of hand, can contribute to the kind of resistance problems that we saw with our patient database.
We have a question, it looks like, from the chat room.
Yes, so a question from Twitter. Kathleen asks, can you speak about decolonizing MRSA or SA nasal carriers by screening on admission and treating carriers with nasal chlorhexidine?
I think that's a question for you.
No. You guys are the guests. Again, that's a great question that your study specifically didn't ask, because it's in the gram-positive world. One of the co-authors of the paper, Dr. Cassie Salgado, that's her special area of interest, and I don't know those data off the top of my head, the value of decolonization of patients that are admitted.
Well, I think, just from reading that literature, I think there's things we do know that would help answer the question and things we don't know yet. But it would appear that decolonization, as a general rule, has efficacy in the hospital for patients coming in and preventing other patients from being exposed to that. And there are ways to decolonize patients. There's a ointment that you can put in somebody's nose that'll clear the infection in most of these patients, at least temporarily. And there are these chlorhexidine baths that were mentioned, and if you put those two together, that's even more effective. But the issue is, having done that, will the patient become recolonized? And I think the answer to that's yes. It's a matter of how soon and in what environment. But often patients go back home and other members of the household are colonized, and that was the source to begin with. And so the patient would rapidly become recolonized in going home.
In fact, I remember previous ICAACs where there have been posters on getting the source of MRSA from your pets. Mm-hmm. And in fact, that was one of the papers, I believe, from last year, where MRSA was coming from the household pet, right, and in spite of decolonization. You've been watching ICAAC Live at the 54th Annual Conference on InterScience on Antimicrobial Agents and Chemotherapy. I'd like to thank you all for your participation and ask that you join us again tomorrow, when we're going to have, again, 3 sessions discussing some of the papers, and we're going to end with a very special session on a topic that everyone is very much concerned about, and that is Ebola. And the session on Ebola will occur at 12 noon Eastern Daylight Savings Time. So if you're interested in learning about what's going on with the Ebola outbreak, please tune in tomorrow at noon. And if not, you can always listen to us on This Week in Microbiology, where you'll hear me, Michael Schmidt, along with my co-host, Elio Schechter from Small Things Considered, Michelle Swanson from the University of Michigan, and Vincent Raccaniello, also of This Week in Virology and This Week in Parasitism. So until next time, thank you for your attendance, and listen for us on This Week in Microbiology, the podcast about the unseen life on planet Earth. Thank you, everybody. Goodbye.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.